The next speaker is Dr. Suzan Amana, and she'll be discussing two different chemoprophylaxis approaches after phacoemulsification surgery in 1,000 patients in Iraq. شنو هذا الchemoprophylaxis approaches? Interesting topic.
Good afternoon. I am Suzan Amana, Assistant Professor in Ophthalmology from Al-Kindi College of Medicine, University of Baghdad. Thanks for the Stern Al-Aziz. Thank you for the scientific committee that give me this opportunity to be here discussing our knowledge and practice with some of common ophthalmological topics. What's mentioned is not my topic. There is a misinterpretation. I want to present a story of a young man, so pay attention. A 20-year-old man with a refractive error asking for refractive surgery. Our patient data, for the right eye, the uncorrected visual acuity less than 6/60, the base-corrected visual acuity was 6/9, and the manifest refraction -8, -4 at 100 axis. The minimum corneal thickness measured by ultrasonic pachymetry was 501 micron, and the steepest and the flattest sky reading measured by the serious topography was 43.9 diopter. This is at 96, while the steepest sky reading was 45.5 at 6 axis. The steepest sky was 45.8 diopter. The anterior chamber depth was 2.1, the photopic pupil 4.2, and the scotopic pupil diameter 6.1. This reading for the right eye. The left eye have the same uncorrected visual acuity less than 6/60. The base corrected was 6/9, and the manifest refraction -8, -3.5 at 85 axis. The minimum corneal thickness was 496, and the anterior chamber depth was 2.4. The photopic and scotopic pupil little bit similar for the right eye. There were no topographic or clinical findings suggestive of keratoconus, and there is no corneal opacity, no any previous ocular surgery in either eye. Let us throw a light about the common known surgical treatment for myopic astigmatism. In general, there are three approaches for correction of myopic astigmatism: either laser keratorefractive procedure, or phakic implantable lens, or refractive lens exchange. Laser keratorefractive procedure have been used to treat a wide range of refractive error and proved to be safe and effective for most of the treated case. While the corneal thickness remain one of the most important physical limit for correction of myopic refractive error by laser, and the optical quality may be not as good as desired when you treat a higher error by laser. So, in case of moderate to high myopia, when the laser surgery is inappropriate or there is risk of biomechanical instability of the cornea, phakic implantable lens is the best option. Regarding refractive lens exchange, it is not a popular approach due to the increased risk of retinal detachment, especially when we treat cases with axial length more than 26 millimeter, and loss of accommodation in a young patient is an important issue. So, according to the given data, what is the refractive procedure that may be possible for my patient? A written informed consent was provided by the patient for the treatment using the MyoRing, and for his preoperative and postoperative data, including the topographic image included in a case report and to be published. And really, this case was published at International Medical Case Report Journal. Now, what about the method? The surgery was done at a specialty private hospital in 3 steps. The steps included, number 1, a femtosecond laser Zimmer ophthalmic system was used to create a pocket, 8 millimeter pocket in diameter, at a depth of 300 micron with a closed circumference except for the incision side that is a 4 millimeter width. The Mayo ring that is chosen is a continuous ring. The diameter used according to the nomogram supplied by the manufacturer. The ring diameter was 5/280, and it was a compressible ring so as to be this is to facilitate implantation through the incision. The ring at the last step was centered through the pocket, and this image A, B, C showing the pocket creation by the femtosecond laser. B was the insertion of the ring through the pocket, while the C, the centration of the ring, which is the last step. Our result was, at 1 week postoperative follow-up, the right eye uncorrected visual acuity showing 6/12, and the manifest refraction -8, -1.25 at 168. The pace-corrected visual acuity is 6/9. While the uncorrected visual acuity at 1 month postoperative visit was 6/9, and this result remained stable at 1 year for 4 years postoperative follow-up visit. At 3 months postoperative follow-up, we did the corneal topography for the patient, and we noticed that there is a shift in the type of astigmatism from the against rule astigmatism to with the rule astigmatism, and there is a flattening, significant flattening of K reading when K1 equal to 38.3, and the SIMK2 was 41.3. As I mentioned, there is a change from the type of astigmatism from against the rule to with the rule astigmatism. The reading maintained throughout the 4 years follow-up period. The left eye was similar regarding the uncorrected visual acuity 6/12, then 6/9, the pace-corrected visual acuity. This is at 1 week, while at 1 month follow-up it was 6/9 plus, and the visual acuity parameter remained stable throughout the follow-up period. What I want to mention that there were no intraoperative or postoperative complication, and the patient was blessed with the result with the right eye, and he is insisted to have the left eye treated by the same manner. The only unaccepted side effect that experienced by our patient is the night glare, especially when we use this smallest diameter of the ring, and for that it was transient, and I used topical pilocarpine hydrochloride eye drop 1% twice daily for 3 months only, and then the patient adapted with the result. This is the sequential tangential anterior topographic image, the preoperative one. And at the middle, it's a 4 months postoperatively, and see the last one 4 years postoperatively. The preoperative image showing the against the rule astigmatism, the middle image showing the flattening effect of the ring that is continued till 4 years postoperatively. As a conclusion, giving the problem with the night vision, Mayo ring may be the only treatment of choice for a small number of patients for whom phakic implantable lens is not possible and laser keratorefractive procedure are contraindicated. Thanks.